Good evening, all. Welcome to Yashoda Hospital academic session. So every week, every Friday, we bring the fourth interesting, relevant, and latest topics in emergency medicine with all our experts. So this week we are with the Journal Club. So this Journal Club is coordinated with three hospitals of three branches. One is from Malakpet, next is from Somajiguda, and the third from Secunderabad, Yashoda. So the first topic what we selected was a MIN trial. This is by Dr. Akhila, who is a final year resident. And the second go topic will be by Dr. Sruthi, is a Cryostat. And the third topic will be by Dr. Geo George Thomas, Lactate and base ductus combination score for predicting blood transfusion need in blood trauma patient. So shall we start? So over to Akhila, now you can go ahead.
Dr. Akhila, is there any concern to share the PPT?
Yeah.
Sir, actually, we're trying it.
Okay.
Yes, sir.
Yeah.
Good evening, everyone. Good evening, Dr. Raghu sir, Dr. Kiran Varma sir, Dr. Bhanu sir. Today, I'm going to present before you the main trial, the myocardial ischemia and the transfusion trial. Coming to the introduction, anemia is commonly seen in patients with acute MI. The indications for red cell transfusion in acute MI patients are controversial due to the lack of substantial evidence. So the guidelines highlight the need for clinical trial data in patients with acute MI for determining optimal transfusion strategies. To the previous trials, a meta-analysis of 3 trials, including 820 patients, were published before mid, but it did not find a difference in the 30-day all-cause mortality with the restrictive versus liberal transfusion strategies. Among this, the largest was the reality trial, which was held in 2021. It showed that the restricted transfusion threshold, they took HB less than 8, was non-inferior to liberal thresholds at preventing the major adverse cardiac events at 30 days. Now, coming to the risks of transfusion, the blood transfusion might reduce the ischemic injury by improving oxygen delivery, but can also lead to the complications like heart failure, infection, thrombosis, and inflammation. There were comparative trials on the transfusion strategies. The studies involving 21,433 patients, 21,433 patients, they compared the restrictive and the liberal transfusion strategies. And in the restrictive transfusion, they showed a reduction, 50% reduction in the blood use without impacting the mortality and the morbidity. So coming to the MIN trial, the research question was, to determine whether the risk of death or MI through 30 days differed between a restrictive transfusion strategy, where the hemoglobin threshold was 7 to 8 gram per deciliter, and a liberal transfusion strategy, where HB threshold was less than 10 gram per deciliter among the patients with acute MI and anemia. So the methodology used here, the study design was an open-label, multi-center randomized control trial, which was held in 144 sites in United States, Canada, France, Brazil, New Zealand, and Australia during a time period of April 2017 to 2023. The population included in the MIN trial were 3,504 patients who were acute MI patients with anemia. In them, the mean age was 72.1 years, among which 45.5% were women and 12.6% were Black. Coming to the inclusion criteria, they included the population age more than equal to 18 years, with STEMI or NSTEMI on presentation based on the third universal definition of MI. The patients with type 1, type 2, type 4B, type 4C MI were included. and HP less than 10 gram per deciliter within 24 hours of randomization. So coming to the MI classification from the third universal definition of MI. Type 1 is spontaneous MI. Type 2 is due to the ischemic imbalance. Type 3, there is a sudden cardiac death when biomarkers values are unavailable. 4A, MI related to PCI. 4B, MI related to thrombosis. And 4C, MI related to restenosis. And type 5, MI related to coronary artery bypass grafting. Coming to the exclusion criteria, those who were having uncontrolled acute bleeding, the participants who declined transfusion, those who were scheduled for cardiac surgery during current admission, and patients receiving palliative treatment were excluded. Now the intervention. In the restrictive strategy group, the transfusion was permitted but not required when hemoglobin is less than 8 gram per deciliter. But it was strongly recommended when HB was below 7 gram per deciliter or the patient was having uncontrolled anginal symptoms. Coming to the liberal strategy groups, there was immediate transfusion of 1 unit of PRBC post-randomization with a goal to maintain the hemoglobin at or above 10 gram per deciliter until the hospital discharge or 30 days. The outcomes. The primary outcome was a composite of MI or death from any cause within 30 days of randomization, and the secondary outcome was the individual components of the primary outcome along with the composite outcome included all-cause mortality, the not-fatal recurrent MI, ischemia-driven unscheduled coronary revascularization, or readmission to the hospital for ischemic cardiac diagnosis within 30 days. And there were also multiple tertiary outcomes. So coming to the statistics, the study enrolled 3,500 patients. It provided the trial with 80% power to detect a 20% relative difference between groups in the incidence of primary outcome and assumed an overall incidence of MI or death at 16.4%. They utilized a two-sided test with an alpha value of 0.05. All analyses were conducted in the intention to treat population with a two-sided hypothesis test for superiority. The risk ratio assessment was used to compare the risk between the restrictive and the liberal strategies, and the values greater than 1 indicates a preference for liberal strategy. And the primary analysis method implemented a long binomial regression model. So this is a study outline of our study. From 3,530 patients, consent were taken. Among them, 24 were ineligible. So 3,506 were randomized. Among this, 1,749 were in the restrictive group and 1,757 were in the liberal group. So the complete data of about 98.9% was obtained from the restrictive group and 97.8% was obtained from the liberal group. Demography. As we explained, age 72 was the mean age, among which 45% were the females, and most of them were like the white population. The index MI was NSTEMI in more than 80%, and 56% of the patients had type 2 MI. The 1/3 of the patients had a history of PCI, 32.5% had prior MI, 21.7% had prior CABG, and 30.4% had heart failure. So the hemoglobin level and number of PRBCs transfused, as we can see in the graph, they started with a hemoglobin of 8.6 both in the restrictive and the liberal group. In the liberal group, it was raised from 8.6 to 10.1 on day 1, 10.4 on day 2, and 10.5 on day 3. Whereas in the restrictive group, it was maintained like 8.6 on from baseline, 8.6 to 8.8 on day 1, 8.9 on day 2, and 8.9 on day 3. And when we are looking at the units of blood transfused, we can see that in restrictive group, 66.3% did not receive any blood transfusion, whereas almost 33.9% received more than 3 units of PRBCs in the liberal group. So total in liberal group was 4,325 units of PRBCs were given, whereas in restrictive 1,237 units were only given. So that was very significant. There was a 3.5-fold difference between the liberal group and the restrictive group. Now coming to the outcome, as we can see, the primary outcome, that is MI and death, it was 16.9% in the restrictive group and 14.5% in the liberal group. As we are seeing this graph, we can see most favorable to liberal strategy, but none of them are statistically significant because they are closing the one value, middle line, the one value. So the primary outcome MI and death, even though it was increased more in the restrictive strategy, they were not statistically significant. Coming to the secondary outcome, death was 9.9% in the restrictive strategy and 8.3% in the liberal strategy. MI was 8.5% in the restrictive strategy and 7.2% in the liberal strategy. Coming to the overall death, MI, revascularization and rehospitalization, 19.6% in the restrictive strategy and 17.4% in the liberal strategy. The pulmonary embolism and heart failure, when we are taking, they were more favorable in the restrictive strategy. So heart failure was 5.8% in the restrictive, and in the liberal it was 6.3%, and the pulmonary embolism was 1.5% in the restrictive strategy and 1.9% in the liberal strategy. So this is the graph is showing the rate of the primary outcome. The first graph is showing the composite outcome of the MI and death. The rate of the primary outcome was more in the 16.9% in the restrictive group and 14.5% in the liberal group. This we have explained. The heart failure at 30 days was not different between the groups, but the restrictive group had fewer transfusion associated cardiac overload events than the liberal group. Coming to the subgroup analysis, in the subgroup analysis, the only difference was seen in patients with type 1 MI, in whom more primary outcome events were seen in a restrictive versus liberal transfusion strategy. The association was not seen in those with type 2 MI. Now coming to the interpretation, in patients with acute MI and comorbid anemia, a liberal transfusion strategy targeting hemoglobin concentration more than or equal to 10 gram per deciliter was not superior to a restrictive target of 7 to 8 gram per deciliter with respect to all-cause death and non-fatal MI at 30 days. But there were a lot of limitations for these studies. The first one, the lack of blinding. And the next was the cardiac cause of death was not centrally adjudicated. Then the moderately strict adherence to transfusion protocols in liberal strategy because of the transfusion-related reactions or transfusion-related circulatory overloads. They have stopped the transfusions. Nearly 90% of the patients participants were from the United States or Canada, making the generalizability somewhat limited. Even though this trial was 4 times larger than the reality, it was underpowered. And it's unclear whether anemia is a marker of comorbidity and whether it should be targeted for intervention. In trauma patients, as well as after acute MI, PCI and CABG, transfusion have been associated with higher risk for mortality. The risk of transfusion may be related to reduced quality from prolonged storage and other complications like graft versus host disease. So coming to the conclusion, the trial results suggest that a liberal transfusion strategy has the potential for clinical benefit with an acceptable risk of harm. Though not significant, there was a trend towards increased events of both the primary composite endpoints and the components in the restrictive strategy arm. Thank you.
Dr. Kiran.
Hello.
Yes, sir.
Yeah. Thank you, Dr. Akhila. That was a nice presentation. So next we'll move on to next journal club. Topic for today is like Cryostat trial. So as we know, we see number of trauma patients where we require blood products. So one among it is like cryoprecipitate. So with the advent of TAG, using of ROTEM, all these things, we are using blood products in a majority of the cases, especially polytrauma. So majority of the people are dying due to lack of blood products and blood. So to study on the effect of cryoprecipitate, especially for polytrauma and class 4 hemorrhage, class 3 or class 4 hemorrhage patients. So there are multiple trials which have come up earlier. So like Cryostat 1 and Cryostat 2, so where they used cryoprecipitates as a part of registration. So now we'll go ahead with the Cryostat 2 trial, which is going to be presented by Dr. Sruthi, final year resident from Somajiguda. Sruthi?
Yes, sir.
Please take out the forum.
Yes. Thank you, sir. Good evening, everyone. I'm Dr. Sruthi, final year resident from Yashoda Hospitals, Somajiguda. Today, I'll be discussing about Cryostat 2 trial. Coming to the introduction, worldwide, an estimate that 5.8 million people die annually from trauma, out of which most of them under the age of 45 years of age. For the same group, this death rate is more than that of cancer, HIV, and heart disease combined. One of the most common causes of death in trauma patients is uncontrolled bleeding. Hemorrhage is exacerbated by a complement derangement of coagulation, including an acute fibrinogen deficiency. Management is fibrinogen replacement along with cryoprecipitate transfusions or fibrinogen concentrate, usually administered relatively late during the hemorrhage, that is after the trauma. The objective of this trial is to assess whether the survival could be improved by administering an early and empirical high doses of cryoprecipitate to all patients with trauma and bleeding that required activation of a major hemorrhage or transfusion protocols in their hospitals. Coming to the aims of this trial will investigate the effects of early fibrinogen supplementation, that is in the form of 3 pools, that is 15 units or 6 gram of fibrinogen of cryoprecipitate with an all-cause 28-day mortality. Coming to cryoprecipitate. Cryoprecipitate is prepared from fresh frozen plasma by thawing it multiple times. It is a concentrate which contains fibrinogen, 1 milliband factor, factor 8, factor 13, and fibrinonectin. Coming to the design of the Cryostat 2 trial. Cryostat 2 was an interventional, randomized, open label, parallel grouped, controlled, international, and a multi-center study. The patients were enrolled to this study at 26 UK and 1 US major trauma centers, having commenced in 2017, and the recruitment of the patients was completed by 2022, and the results were published in October 2023. Coming to the inclusion criteria with which the patients were accepted into this trial. Those are an adult trauma patient with age more than or equal to 16 years, patients with severe injury with evidence of active hemorrhage requiring activation of local massive hemorrhage protocol, and patients who have been started or received at least 1 unit of any one blood component, and systolic blood pressure less than 90 mmHg at any point after the trauma. Coming to the exclusion criteria of the patients from this trial, a patient will not be eligible for this study if he or she fulfills 1 or more of the following criteria. That is, if the patient has been transferred from another hospital, or the trauma leader deems that the injuries which the patient sustained are incompatible with life, or if more than 3 hours have elapsed from the time of injury, that is, hemorrhage has started. Coming to the intervention. In this study, the patients were randomly assigned in a 1:1 ratio, in which one group received standard care, that is, following the local hemorrhage protocol, which is 1:1 ratio of FFPs, platelets, and packed red blood cells. In the other group, in addition to this major transfusion protocol, these patients also received 3 pools of cryoprecipitate, which includes 6 gram of fibrinogen, which is administered within 90 minutes of randomization and within 3 hours of the injury. Coming to the outcomes, the primary outcome is all-cause mortality at 28 days. And additional secondary outcomes include all-cause mortality, including death from bleeding at 6 hours, 24 hours, 6 months, and 12 months from the admission. Death from bleeding at 6 hours and 24 hours. Transfusion requirements, that is number of units of RBCs, platelets, FFPs, cryoprecipitates at 24 hours from admission, including the pre-hospital transfusions. And the destination of the participant at the time of discharge from the hospital, quality of life measures, including Glasgow outcomes care at discharge and 6 months after injury. Hospital resources used up to discharge or day 28, including the blood transfusion, surgical procedures performed on the patient, the number of ventilator days, or the hours spent by the patient in critical care and inpatient stays. And symptomatic thrombotic events, including venous thromboembolism and arterial thrombotic events like MI and stroke that have occurred after the hemorrhage. Coming to the results of this trial, among 1,604 eligible patients, 799 were randomized to the cryoprecipitate group and 805 to the standard care group. Missing primary outcome data occurred in about 73 patients, principally due to their withdrawal of the consent, and 1,531 patients, that is about 95%, were included in the primary analysis population. And the median age of the participants was around 39 years, with a median injury severity score of 29. And 26% had severe head injury, 36% of the people had penetrating injury, 33% of the people had a systolic blood pressure less than 90 mm of Hg at the arrival to the hospital. Coming to the results, the all-cause 28-day mortality in the intention to treat population was 26% in the standard care group versus 25.3% in the people who received the cryoprecipitate. The odds ratio being 0.96, with a confidence interval of 90% of the odds ratio being 0.75 to 1.23, and the p-value being 0.74, which means there is no difference in the safety outcomes or the incidence of thrombotic events in the standard care versus the cryoprecipitate group, that is 12.9 versus 12.7%. This is an outline of the trial, where the population, out of which 1,251 men and 330 women were included, patients more than 16 years of age, median age being 39 years. Locations are the 26 major trauma centers over the UK and one in the US. And in the intervention, people being assorted to cryoprecipitate 799, standard care right now 5 people. Primary outcome was the all-cause mortality at 28 days. Coming to the findings, the cryoprecipitate participants 25.3 and the standard care 26.1, which shows that there was no improvement in mortality. Coming to the discussion, as per Cryostat 1, early fibrinogen supplementation using cryoprecipitate was feasible in trauma patients. And this study supported the need of a definitive randomized control trial to determine the early fibrinogen supplementation on mortality and other clinical outcomes. Thus, Cryostat 2 trial was being conducted. In Cryostat 2, there was no difference in mortality between the patients who got high-dose cryoprecipitate and those who received high standard of care, that is the transfusion protocol, major hemorrhagic transfusion protocols, which was followed at their local centers. Further, the results fit with the current thinking that one size fits all does not work for trauma patients and requires further research to see if blunt versus penetrating trauma are phenotypically different. We need to bring early diagnostic tests close to the patient in the emergency room or pre-hospital care at the scene to allow more precision approaches to treat severe bleeding and abnormal clotting. Giving early empiric cryoprecipitate most likely results in a substantial proportion of patients receiving fibrinogen who did not develop fibrinogen innate. So this is a negative trial. This trial would advocate for a precision-guided coagulation therapy. Coming to the conclusion, among the patients with trauma and bleeding who required activation of a major hemorrhagic protocol, the addition of early and empirical high-dose cryoprecipitate to standard care did not improve all-cause 28-day mortality. There was no difference in safety outcomes, transfusion requirements, or the incidence of thrombotic events across the study groups. Coming to the limitations of the study, convenient sampling of patients, which could cause selection bias. That is 888 patients not randomized due to unavailability of the research team. Due to lack of a placebo group, it is difficult to examine the effect of timing of cryoprecipitate administration on the outcomes. A blood sample to determine fibrinogen level prior to the cryoprecipitate administration was not required because some patients have already received cryoprecipitate without having low fibrinogen levels. A blood sample to determine fibrinogen level prior to cryoprecipitate administration was not required. Some crossover between the groups. 15% of patients in the cryoprecipitate group did not receive cryoprecipitate, and 9% of patients in the standard care group got cryoprecipitate within 90 minutes. That is 32% within the 24 hours. This could dilute any beneficial effects that could have been seen due to the Cryostat 2 trial. Lack of blinding may bias the results. Although mortality is a solid objective primary outcome, bias may still creep in terms of management. Finally, coming to the clinical implications, cryoprecipitate should be continued as an on-demand addition to a balanced transfusion strategy, which could be guided by laboratory values such as TEG, ROTEM, INR, ABTT, and bedside if possible, along the laboratory values, and should not be given empirically. Thank you.
Thank you, Dr. Sruthi. Thanks for your nice talk on Cryostat 2. So now I'll hand over the forum to Dr. Bhanu, who is consultant ER physician at Secunderabad, to take it forward. Bhanu?
Yeah, thank you,
Please
sir.
take it forward.
Yeah, that was a great presentation. Good evening, everyone. Dr. Geo will be presenting on lactate-based combination score for predicting blood transfusion trauma patients. Over to you, Geo.
So, good evening, everyone. Thank you, Bhanu sir. Today, my journal club discussion will be based on lactate and base deficit combination score for predicting the blood transfusion need in blunt multi-trauma patients. So, I am third year resident. My name is Dr. Geo George Thomas from Yashoda Secunderabad branch. So, this is the original article which was published in Turkey by Emergency Medicine Department. And coming to the clinical question we raised, in a critically ill blunt multi-trauma adult patients admitted to the hospital from the emergency department, thus the lactate and base deficit combination score can be used for blood transfusion. So coming to the background or introduction, multi-trauma is a term used for severely injured patient, used usually with multiple injuries or less often with 2 or more severe injuries in at least 2 or more areas of the body. Ongoing hemorrhage can lead to the lethal triad of death that everyone knows: hypothermia, acidosis, and coagulopathy. The most important cause of death in the first hour after trauma is bleeding. Coming to the lactate and base deficit values are parameters which are used in indicators for tissue perfusion, and for many years they have been used as a biomarkers for severity of injury and mortality in sepsis, shock, and trauma. Coming to the design or materials and methodology, this was a single-center randomized open-label multi-crossover study, and a multiple variable proportional odds model was used to assess the primary outcome of predicting the need for blood transfusion in blunt multi-trauma patients within 24 hours. And multi-variable logistic regression analysis was performed for the secondary outcomes in this study, which they aim to compare the patients who had blood product treatment within the 24 hours with the patients who do not have this kind of treatment in terms of variables. Coming to the variables we have taken, patients' demographic data they have collected in that age, sex, mechanism of injury, clinical characteristics such as vital signs like systolic blood pressure, diastolic blood pressure, heart rate, respiratory rate, peripheral oxygen saturation, Glasgow Coma Scale, laboratory values like HB, hematocrit, lactate, base deficit, pH, shock index, and revised trauma score, and the necessity for blood transfusion in 24 hours were obtained from the hospital records. Lactate, base deficit, and shock index were characterized based on the cutoff in the journals or literature, respectively. Two lactates were taken as 2 moles per liter. Base deficit was taken as less than -6 millimoles per liter, and shock index was taken as more than 0.9. Coming to the probability value less than 0.05 was recognized as statistically significant. We have calculated the sensitivity, specificity, and positive predictive value and negative predictive value for the groups for outcome measurement. To compare the performance of lactates, base deficit, and lactates and base deficits with the shock index and revised trauma score in predicting blood transfusion, we have used a receiver operating curve also. In lactate and base deficit combination score for predicting blood transfusion need in blunt multi-trauma patients, they have used the same receiver operating curve were constructed, and the area under the curve was calculated, which the graph I will be showing below. Settings or this study was conducted in a single center study in a trauma center, level 3 trauma in Osman Gazi University in Turkey. The study time period or the patients were recruited from January 1st, 2018 to December 31st, 2018. Coming to the study population, inclusion criteria was only 18 years old or older patients with the blunt multi-trauma patients whose initial blood lactates and base deficit were measured and were included in the analysis. Coming to the exclusion criteria, those with burns, non-hepatic disorders, renal failure, malignancy, shock due to spinal trauma, pre-hospital cardiac arrest, drug use that may affect the heart rate, penetrating trauma, drug poisoning, as well as patients who refuse the treatment and patients without blood gas measurements at the time of admission to the ED, and pregnant females were also excluded from the study, so that injuries that cause the derangement of the heart rate or any other parameters were excluded from the study from starting itself. So coming to the data collection they have done and the data source, lactates and blood base deficit levels of venous blood samples obtained within first 10 minutes of admission to ED or emergency department before any invasive procedures like intubation, mechanical ventilation, or treatments were analyzed within 15 minutes to prevent any additional metabolism. And this data was analyzed with a radiometer, and the logistic regression analysis was used in the linear combining, and the equation was obtained to estimate the need for blood transfusion in 24 hours after combining. The equation is shown below, blood need probability value after combining the lactates and base deficit. Based on the equation results higher than 0.92447509 was considered as a blood transfusion necessity for the patient. Coming to the results part, the study included a total of 359 patients who were admitted to the emergency department due to blood multi-trauma, and in that 207 or 57.7% of patients have lactates more than 2 millimoles per liter. That I have mentioned above, that was our cutoff. And in 44 patients, base deficits was found to be less than 6 millimoles per liter. And number of patients where both measurements were abnormal was 39 or 10.9%, and shock index was more than 9.9 in 68 or 18.5%, and coming to the combination score, which was more than 0.09, that value I told earlier, in 100 patients, that 27.85% of patients. The number of patients who received blood transfusion within 24 hours out of 359 patients was only 49. This is the graph showing blood transfusion and non-blood transfusion group. In that we can see transfusion was received in only 49 patients. Non-transfusion was received in non-transfusion group is only 310. And In the interesting part is HB is normal in both cases. It is 12.7 in transfusion group and non-transfusion group. It is 14.55. And other parameters we can see all are significant. P-value is less than 0.01. Lactates are 3.8. In median value is 3.8. And lactate in non-transfusion group was 2.1. And base deficit was minus 6.6 median value. And non-transfusion group, it was 0.9. Coming to the, we have done a comparison with all the parameters. In that, lactate value have a positive relation. In their study, the lactates value have a positive correlation with the shock index, heart rate, and a negative correlation with the base deficit, revised trauma score, and systolic blood pressure and diastolic blood pressure. And base deficit value has a positive correlation between revised trauma score, systolic blood pressure, diastolic blood pressure, HB, and hematocrit, and a negative correlation between shock index, heart rate, and respiratory rate. Coming to the analysis of the data, a threshold value, as I mentioned 2 times previously, 2 millimoles per liter for lactase and minus 6 millimoles for base deficit was taken, and 0.09 was taken for shock index, and for the combined score, it was 0.092447509 based on the equation. For the patients who received blood transfusion in 24 hours, they have calculated the sensitivity specificity in that lactates more than 2 millimoles were found in 43 out of 207 patients who have lactate more than 2 millimoles. And the sensitivity was found to be 87.8%. Specificity was less, it was only 47.1%. Coming to the base deficit, which was less than 6 millimoles per liter, was found in 26 out of 44 patients. 44 patients who is having base deficits less than 6 millimoles per liter. And in that, specificity was found to be 94.2%, but sensitivity was found to be only 53.1%. Shock index more than 0.9 was found in 68%. Out of that, 30 people received blood transfusion. So specificity was high in that also, 85.5%, and sensitivity was only 61.2%. Coming to the combined score, which is more significant here, more than 0.092 that value I mentioned earlier was taken, was found to be in 100 patients, that value in 359, 100 patients had value more than 0.09 patients. Out of that, 41 patients received blood transfusion. And in that, we can see sensitivity value is 83.7 and specificity is 81%. Both sensitivity and specificity values are high. And that chart is plotted here that I mentioned earlier. Coming to the receiver operating curve that was plotted for a lactate, first receiving operating curve that was plotted for lactate and base deficit and shock index and revised trauma score. And based on that, every value will be having more area under curve was found to be significant for every value. Coming to the second graph, which was for shock combined score of lactate and base deficit, and shock index and reverse trauma score was calculated. In that, shock index was found, combined score was found to be more significant predictor than lactate and base deficit alone, because area under curve was more for combination score measurements than lactate, base deficit, shock index, and reverse trauma score. Coming to the discussion part, in this study revealed that shock combined score measured at the time of admission to the emergency department might be beneficial to predict blood transfusion necessity in 24 hours in blunt multi-trauma patients brought to a level 3 trauma center, and may be more valuable than lactate and base deficit alone. And shock index and revised trauma score in determining the blood need within 24 hours. Revised trauma score and shock index are physiological scoring systems, and its accuracy is very high in predicting mortality. But studies are very less comparing the revised trauma score and shock index with the combined score for blood transfusion. This report is very unique because it is the only evaluation of combined score with lactate, base deficit in blunt multi-trauma patients. Coming to the limitations of the study, this study was a single standard study the shock index calculator was not repeated, and all patients were referred with emergency medical system. And because this was a level 3 trauma center, the vascular access was open already. Initial fluid resuscitation was started. Pre-hospital shock index or vital value measurements and the exact amount of fluid they received would not be evaluated in this study. And as min trial previously they have mentioned in the min trial also, the ethnicity group also differs. Like here only it was done in Turkey, so only we are not able to compare between other populations. And the study size also was comparatively very less. And coming to the conclusion, in this study, it was found that combined score is more effective than lactates, base deficit, shock index, and revised trauma score measurements with higher sensitivity and specificity. This becomes an advantage in early prediction of patients' outcome. Both tests, especially the combination with the formula of lactates and base deficit parameter, should be evaluated more in further studies, and it should be incorporated into our ABGs. And the more studies has to be done. And here additional point is that we should not rely on HB for blood transfusion. Like HB values will be normal after 24 hours also, like not after 24. Initially HB values will be normal. So it is not a criteria for blood transfusion in any trauma patients. Thank you.
Thank you, Geo. That was a nice presentation.
Dr. Raghu sir, any? Sir, you're in. Please unmute, sir. Raghu sir.
Are there any questions posted in the group, or do you have any points to discuss?
So far, no questions, sir.
No questions posted on this.
Bhanu, anything you want to add on Cryostat 2 or hemoglobin in MI patients? So far, no questions. Geo George, it was nice presentation. Thank you, man. It was nice presentation. Dr. Sruthi, do you want to add anything? Dr. Akhila? Nothing. Dr. Geo George, you want to add any points? Please unmute. Geo George, please unmute.
Nothing, sir. Basically, we have selected this study based on lactate and base deficit. Basically, we have to show that HB is not a criteria, like not emergency physicians. Other consultants will be also depending upon HB as a criteria for blood transfusion. So HB is not a criteria. That was our basic thing we have to about to discuss. Lactate and base deficit, and we can rely upon further scoring systems or anything.
Exactly, Geo. It was nice. So overall, nice presentations from all of us. So if you want to conclude, or if you want to summarize, one is one study from Akhila saying that hemoglobin, especially like a liberal group versus restricted group, there is no much of difference in mortality outcome. Then when it comes to Dr. Sruthi, so Cryostat trial, so there is in that also same thing, not much of difference whether you use, if you don't use, so there is no much of difference. Then from Dr. Geo George, as you said, shock index or by base deficit. So if you do it alone, there is no much of difference. If it is a collective score system, yes, there is it's making a lot of difference. It will be useful as well. So that is how we can conclude among all the three things. Dr. Raghu sir,
Yeah,
anything
Kiran?
you want to add, sir?
Yeah, nothing, because the first two studies did not give any positive note,
Yeah, true, sir.
neither the MI or the Cryostat.
So there is a question, sir. So what if hemoglobin is less than 7? No need to transfuse. Akhila? I think it is related to your topic.
Yeah, according to the study, they are telling we can take the risk and go with the transfusion. Because even though statistically non-significant, the restricted group were the primary composite outcomes were more in the restricted group.
Yes, true.
So normally we keep the HB around 7 to 8. So if it is there any with symptoms only, we try to transfuse hemoglobin for these patients.
Especially
In
cardiac
ICUs
patients.
also we keep the HB around 7 to 8, not to overload or not. Only positive thing we get is if you transfuse, only we can expect there is a good oxygenation to the tissues and a better outcome.
Okay, sir. Bhanu, anything you want?
Nothing, sir.
Nothing. Raghu sir, can you conclude?
Yeah, overall a good presentation by Dr. Akhila, Dr. Sruthi, and Dr. Geo George.
So I thank Kondle, especially our presenters like Akhila, Geo George, and Sruthi, Dr. Raghu sir, and Dr. Bhanu. Then, so thanks for the opportunity given by Dr. Srinath sir and Yashoda Group of Hospitals. I thank Semi Board and NBI for your association and for support for conducting all these things. I thank all the spectators, viewers of our webinars. Thank you, Kondle.
Thank you, everyone.
Thank you.
Thank you, everyone.
Bye.